Go well. Bye.
Johnny and the Mix.
أحب أشكر الأستاذ الدكتور مجدي والأورجنايزنج كوميتي على دعوتي for this meeting، وأشكر طبعا سانوفي for inviting me for their symposium، وأشكر الحضور دكتور تشارلز and الأستاذ الدكتور أحمد القريعي. My talk will be about hypertension in diabetes. I'm Dr. Mohammed Halab, professor in endocrinology at Shams University. I will start my talk with an index presentation. This case is a 60 years old male type 2 diabetes, diagnosed at the age of 45 years, come for routine re-evaluation, no complaints that time, no past family history of coronary, cerebral, or peripheral arterial disease. His medication include metformin 1,002 times per day and glimepiride 4 milligram once per day. On physical examination, he was a mildly obese male with repeated blood pressure 150 over 90 and no evidence for retinopathy. Other clinical examination are remarkable. The lab results showed HbA1c 6.8, serum creatinine 0.9, blood urea nitrogen is 8, and urine analysis grossly negative for proteins. The question now, what he should be treated with which one of the following regarding at least for the blood pressure. As we see here, the HbA1c is within the target less than 7 based on ADA guidelines. What's your choice? Lifestyle modifications is enough for that patient, or thiazide diuretics, cardioprotective beta adrenergic agonist, or RAS blockade, either ARB or ACE inhibitor or calcium channel blocker. This is my first question or first case. And what if we turn with the same case, same criteria, but the lab results showed that urinary albumin creatinine ratio is 140 microgram per mg, repeated 3 times with a similar figures. What's the best treatment option. Again, the same lifestyle modification, thiazide diuretics, cardioprotective, beta-adrenergic agonist, RAS blockade with ARB or ACE inhibitor, or calcium channel blocker. I think the answer will reflect the base guidelines as we will review on the next slides. As we all know, the traditional major risk factors for coronary artery disease include the cigarette smoking, hypertension, low HDL, family history of premature coronary heart disease, and the age, male more than 45 and female more than 55 plus, the exclusive the LDL and diabetes. Focusing on the hypertension is a very important risk factor, and there's a correlation between the systolic blood pressure and cardiovascular. This, as we see here from the Mr. Fit trial, the multiple risk factor intervention trial, increase both for diabetics and non-diabetics risk of cardiovascular mortality, and the risk in diabetics nearly double the risk in non-diabetics. Again, a similar evidence from the epidemiological analysis from the UKPDS with excess or increased estimated risk of increased cardiovascular morbidity and mortality, as we see here with increasing systolic blood pressure. Hypertension in general present in 20 to 60% with diabetes. In type 1 diabetes, hypertension reflecting the onset of diabetic nephropathy, and in type 2 diabetes, more than 50% even have hypertension before the onset of diabetes. Hypertension is a strong risk factor for deterioration of kidney function over time. As we all know, and as we see from this study, the increased blood pressure will be associated with a reduction in GFR, but with elevated blood pressure more than 140, the decline in GFR is progressive and usually leads to loss and the difference about 4.5 years with to the time of dialysis with progression of kidney disease with hypertension. Microalbuminuria is a key determinant and intermediate endpoint disease process in all diabetic. It predicts accurately more advanced complications with diabetes. It predicts the development or the development of overt nephropathy and renal failure, and predicts the development of cardiovascular disease in type 2 diabetes. Fortunately, and thanks God, the intervention trials with the hypertension control, a lot of trials using different treatments like UKPDS, they used the captopril and atenolol, CHEP, chlorthalidone, atenolol, the hot cyst euro, the CAB, and the HOPE, with different showed a significant reduction in cardiovascular morbidity and mortality, and it looks more in the diabetics compared to the non-diabetics, as we see here. Again, this is from the recent trials, the ACCORD, the ADVANCE, the HOT, and the SPRINT trial, a similar benefit for the reduction of the cardiovascular morbidity and mortality in patients with controlled blood pressure. It was calculated from the UKPDS that a reduction 10 millimeter mercury systolic blood pressure leads to significant reduction in different diabetes-related endpoints, as we see here, 12%. Diabetes-related endpoints, diabetes-related deaths 15%, microvascular complications 13%, and myocardial infarction 11%. Angiotensin and RAS system is central in the pathophysiology of renal disease, as we see here with angiotensin 2, the end product of the RAS system will lead to inflammation, cell tissue damage, hyperfiltration, glomerular capillary hypertension, and glomerular pressure injury, and this will accumulate into glomerular sclerosis, reduction in nephron, and will end with chronic kidney disease. Actually, a lot of trials showed a benefit of RAS blockade, and RAS blockade either with ACE or ARBs. We will show here some of the data from the RAS blockade as an important fund from the Magellan trial. One of the interesting and most important trials with RAS blockade and kidney function is the IRMA2, the irbesartan microalbuminuria type 2 diabetes in hypertensive patient study. And this study was a randomized multi-center, double-blind, placebo-controlled to evaluate renal protective effect of irbesartan in hypertensive population with type 2 diabetes and microalbuminuria, with a total population of 590, range from 30 to 70. This patient has hypertension with systolic more than 130/50, with diastolic more than 85. Persistent microalbuminuria in the range from 20 to 200, and serum creatinine no more than 1.5. Actually, this is the results. There is a significant reduction in the incidence of progression to diabetic nephropathy, especially with the dose of 300. And this is the data. Irbesartan reduced the level of urinary albumin excretion 24% in the 150 milligram group, and it was not significant, but 38% in the 300 milligram group, and it was a highly statistically significant. The summary for this IRMA2 trial: irbesartan significantly reduced the rate of progression from microalbuminuria to diabetic nephropathy. Renal protection from irbesartan in patients with type 2 diabetes and microalbuminuria is independent of the blood pressure lowering effect. Another evidence from a larger and with a clinical outcome trial on the side of the progression of kidney disease, the IEDNT, or the Identity irbesartan in diabetic nephropathy trial. It was again a randomized double-blind trial to determine if irbesartan versus the calcium channel blocker amlodipine to slow the progression of diabetic nephropathy, and with the total population 1,715 patients aged from 30 to 70, diagnosed type 2 diabetes, again systolic blood pressure more than 135 and diastolic more than 85, and we have a nephropathy at least 900 milligram proteinuria, and the serum creatinine from 1 to 3 milligram in per dl in female, 1.2 to 3 gram in male. And this is the data. The primary Compton point was significantly reduced statistically in the progression of on irbesartan group, and this constant point includes doubling of the serum creatinine, end-stage renal disease or death, compared to the placebo and the amlodipine group. This account for 20% relative risk reduction in the primary Compton endpoint with the irbesartan group. Again, the summary of IDNT, or the IDENT, in hypertensive type 2 diabetic patients with nephropathy, irbesartan reduced the incidence of primary Compton endpoint of doubling serum creatinine, end-stage renal disease or death by 23% versus amlodipine and 20% versus placebo. This benefit were above and beyond those attributable to blood pressure function. Actually, this is a relative comparison of or differential analysis of ARBs and the intra-class difference according to FDA and EMEA, with the indication of ARB as immunotherapy based على evidence and availability of morbidity and mortality, as we see here in this on the slide on the right-hand side, that irbesartan is indicated. Our approval is the only indication for ARB for type 2 diabetic hypertensive patient, regardless of the stage of end of renal disease. And I think I will conclude my talk to summarize the most important point based on the standards of medical care in diabetes from the American Diabetic Association 2020, the cardiovascular disease and the risk management. Hypertension is a common diabetes comorbidity major risk factors for atherosclerosis, atherosclerotic cardiovascular disease, and microvascular complication. Antihypertensive therapy reduces atherosclerotic cardiovascular disease event, heart failure, and microvascular complication. For patients with diabetes and hypertension, blood pressure target should be individualized based on cardiovascular risk, potential adverse effect of antihypertensive medication, and the patient preference. So for individuals with diabetes and hypertension at a higher risk, with atherosclerotic cardiovascular risk 10 years more than 15%, the blood pressure target better to be less than 130/80. This is appropriate if can be done safely. The patient with diabetes and hypertension at a lower risk for cardiovascular disease with the 10-year risk less than 15, target appropriate less than 140/80. The approach for treatment, we shouldn't forget that lifestyle is very important, and this should be sought with blood pressure more than 120/80. Lifestyle intervention consists of weight loss if overweight and obese, DASH diet, style eating pattern including reducing sodium, increased potassium intake, moderation of alcohol, and increasing the physical activity. For pharmacological intervention, patient with confirmed office-based blood pressure more than equals or more than 140/90 millimeter mercury, in addition to lifestyle modification, prompt initiation and timely titration of pharmacological treatments to achieve blood pressure goal is important. With confirmed blood pressure more and equal to 160/100, a prompt initiation and timely titration of two drugs or a single pill combination of a drug demonstrated to reduce the cardiovascular event in patient with diabetes, the level of evidence recommendations A. Treatment for hypertension should include drug class demonstrated to reduce cardiovascular events in patient with diabetes, ACE, ARBs, thiazide-like diuretics, and the dihydropiridine calcium channel blockers. All these four groups has an evidence from large trials with reduction of cardiovascular disease in hypertensive patients with diabetes. Again, pharmacological intervention, diabetes in general, a multi-drug therapy generally required to achieve the blood pressure target. However, combination of ACE and inhibitor and ARBs should not be used because there is maybe progression of kidney disease. ACE and ARBs at a maximum tolerated dose is recommended as a first-line treatment for hypertension in patients with diabetes and urinary albumin creatinine ratio more than 300 milligram per gram creatinine or 30 to 300 milligram per gram creatinine. If one class is not tolerated, the other class should be substituted. This is a simplified algorithm for recommendation of treatment of confirmed hypertension in patients with diabetes. If the blood pressure confirmed more than 140/90, we have to start the lifestyle management and start one agent. An important question will be asked if there is albuminuria. If yes, we have to go for a RAS blockade, either ACE inhibitor or ARB. If no albuminuria, we can start any of these groups, ACE, ARBs, calcium channel blocker, or diuretics. If the blood pressure is higher with systolic more than 160 and diastolic 100, yes, we have to start lifestyle management and start a combination of two drugs or single pill combination. And important questions again to be answered if there is albuminuria or not. If albuminuria, so one of these drugs should be either ACE or ARBs plus either calcium channel blocker or diuretics. If no albuminuria, we can start of any two of three options is CCP or diuretics. And we should assess the blood pressure control and adverse effects. If we achieve treatment tolerated and reached, we continue the therapy. If the treatment target is not met, add another agent from a complementary drug group, ACE or ARBs, if not used initially, calcium channel blocker or diuretics. If adverse effect is occurred, we can consider an alternative medications, assess the blood pressure, control the blood pressure and adverse effect, and treatment control to continue. If not, we can add in a resistant case mineralocorticoid if we achieve more than two, with one of them is diuretics. I think with this, I came to the end of my talk, and thank you very much for giving me this opportunity, and thank you for the attendees.